Yeah, it doesn't want to start. Oh, here we go. Okay, so I was supposed to talk about the management of large renal calculi, supine versus prone, but looking at that again in the last week, that seemed like quite a stupid topic, to be honest. My talk's probably a little bit different. So if you look at the guidelines when it comes to large kidney stones, and large being greater than 2 centimeters, these are the EUA guidelines. They say that you should do a PCNL as your first choice, and you can do endoscopic management or ESWL. Further, it says that you could consider a pyelolithotomy laparoscopically if the stone's big and in the pelvis and it's a solitary stone, and you can even consider a laparoscopic, a robotic assisted laparoscopic pyelolithotomy if they've got a big extrarenal pelvis and they've actually got a stag-on. So the last option, something that I used to do a lot of when I started my career, and this is the reason I had to learn PCNL, is open stone surgery. And in all the guidelines, they say that it's only a last resort, and you should only consider it in very, very few patients where you have the back against the wall. But if you look at stone surgery in Africa, most stone surgeons are actually still doing a lot of open stone procedures, despite those guidelines. And in terms of giving us direction on what we should be doing for large stones, that's really about it in the guidelines. So there's not really much more where to assist us. So I do a lot of stone work, a lot of PCNLs, and this is really what my life feels like. You spend your day banging your head against the wall trying to get these stones out, and at 5 p.m. either you're happy because you got the stones out, or you're happy because you're going home and you no longer have to look at a stone. So what I'd like to show you here is just some of the things I've learned. I call it the Carol's Guide to the PCNL, and how to cheat and sometimes win. So these are the stones that, especially when you're starting out with PCNLs, or if you're feeling weak, you should try to avoid, and perhaps call in sick if you have one of these. And obviously it's the full stag. It's the patient that's got a lot of small little calyces packed full of stones. Patients that have got retained stents are challenging, but specifically the ones that have got the beads of stones along the straight length of the stent. Obese patients are very challenging for many reasons. The visualization, the positioning is a challenge. If you have calyces that are packed, or a piston that's packed that's undilated, also a challenging stone. Stones where you can only access calyces with thin cortex, that's because they leak. If you have very hard stones like cystine or calcium oxalate stones, those are also a challenge. In the cystine stone group, you can pray that they've had some infection, because if there's a little bit of struvite inside that stone, it makes it a hell of a lot softer and easier to fragment. The patients where they have a retrorenal colon, that creates space for your window to perk them. The patients that have got a large stone filling a calyx in where there's an undilated pelvis, those are also sometimes a challenge to access, especially if you've got colon that limits your access directly to that calyx, and patients with conduits. So the patients where you can expect drama, those where you're going to probably have a lot more bleeding or problems, are the ones where you generally, it's the stags. The stags have almost all of these issues in common. But if you have to do multiple tracts, you have a high risk of bleeding. If you do an upper pole tract, if your procedure is longer, if it's an infection stone, and if you use an existing tract. Some of these are modifiable, but obviously some are not. So I'm just going to go through some points. I'm going to say how to avoid the drama. So this is the first void: plan for the worst, expect the best. So we always do a group and screen. If there's infection, or even if there's an asymptomatic bacteriuria, you should be treating it. You should always under promise and over deliver. Never promise a patient you're going to get the stone out. It really does put you in a position where you are struggling, and you feel because you've promised to remove the whole stone, you then push ahead, and that really does make you run into a lot more issues. Have everything that you need, every single consumable, and more. It's useful to have one of these guys. This is a K nephrostomy balloon. It's the picture here. It's literally the sense starting tube of the PCNL. It delivers pressure to the entire length of the tract and has a drainage kind of lumen through the middle. You can even put a uretary catheter through it. And this you literally blow it up, and you don't make it too tight. You make it tight, and you blow it up enough so that you can bend it. And then you pack some things around it, around the skin, and you bend it over like that and secure it. It's quite useful if you have a bleed from the tract. You can also put it in afterwards if you still have access and they get a delayed bleed. So it's also very important to plan your tracts. CT scan is essential for that, so that you know where you're going. And learning to do ultrasound perks really can improve the safety of your procedure. So one of the biggest things we do before is we kind of look at the conformation of the stone, look at where the colon's lying, and pick the correct calyx. It's important because you need to try and pick the calyx which is going to give you the access to the bulk of the stone, which is often the pelvis. But it's also important to consider what access is going to give you the access to other calyces that have stones in, and access to the PUJ. So previously we used to make this decision on the table when we did our retrograde, but with CT scanning now it's a lot easier. You can make those decisions pre-operatively. So the second is point in how to avoid drama is don't poke the bear with a stick. So the PCNL is a little bit like going to Christmas lunch with your mother-in-law. If she hates you, you have to be careful at every single point, because otherwise things can blow up and can deteriorate into a horrible situation. So one of the first things you need to know is the anatomy, and where is the lung. So if you're doing prone perks, just to note here, this is supposed to show that the more medial your perk goes, the higher your risk of traversing the pleura. If you go above the 12th rib, your risk for pleural, to hit the pleura is low. But as soon as you go above the 11, you should anticipate problems. And so it literally goes up from less than 5% to over 20% injury to the pleura. So it seems quite simple. You know where the kidney is, you know it's at a little bit of a 30-degree angle, and you're just going to go in there, but it's unfortunately not that simple. You have to know a little bit more. And if you look at this, the way that the kidney is angled, so the upper pole is closer to the spine than the lower pole, but the upper pole is also closer to the posterior aspect than the lower. The lower pole is further away from you, and that's important to know when you're planning your tract. Also, some other applied anatomy. Most of the models show you the kind of the relation of the anterior and posterior calyces to each other, and this is in relation to the interpolar calyces. If one looks at the kind of the orientation of the polar calyces, you can see they're actually dead vertical. So that also does change how you're going to approach those calyces when you hit them, both for access issues, but also in terms of if you want to hit the papilla head on and not go through the infundibulum. So we all grew up with these, the Brodel and the Hodgkin kidneys, but I haven't really found this quite very helpful. And I've been spending the last 10 years trying to find this avascular plane, but it has eluded me. If anybody finds it, please tell me. So not going to speak a little bit any more about that. Just also to note that it's not only the kidney that bleeds, you also have these intercostals, and they can be quite nasty, especially if you're going quite near to the bottom of the 12th rib, or if you're going between the 11th and the 12th. Sometimes these can bleed quite a bit. We often do put nice big mattress sutures in if we can see that it's a superficial bleed, and they do help quite a bit, but also something to note. So classically, this is how you're supposed to perk. You're supposed to perk the papilla end on like this to reduce bleeding. But there is also evidence, at least I think 2 publications by Latsiakos, that has shown that there's no increase in bleeding or transfusion rates if you do infundibular perk in the interpolar region. So although we always aim for that, it's not always possible, and we don't get too stressed about it in the interpolar region if we have to perk slightly off the tract of or the perfect line of the calyx. Although they do show you that, if you can see that previous picture where the interlobar arteries are, this is really the kidney's blood supply is not that predictable. You stab the kidney, it bleeds. One of the things which is probably the most useful information is that you need to get into the collecting system with your sheath. If you're outside of the collecting system, it bleeds. You might see stone in front of you, but if you're not in the collecting system, there'll be a large amount of bleeding around the scope, which you might not see. And that's the problem. Get the sheath into the collecting system properly, and that will tamponade most of the bleeds in the tract, and you'll be able to continue your procedure. The other, it sounds quite logical, but if you want to look around corners, you need to use a flexible scope. So this is pretty much the Demolition Man nephroscopy, and it happens when you can just see a stone in the calyx around the corner, and you just can't get there, and you're at the limit of the infundibulum. So you just torque your scope a little bit more, and for 1 second you can see the stone beautifully, and then it just all goes red. And this is really just because you've torn the neck of that infundibulum, and it's just tears, and that's often the end of your procedure. So if you want to look around a corner to go and fetch a stone, use a flexible scope, or plan your perks better and have a perk in that calyx too. You can't get around corners with a rigid scope. One other thing is to beware the colon, specifically in thin females. For us, it's not that much of an issue because we CT most of our patients, and because we use the ultrasound. Be careful patients that have had previous surgery, especially in the recurrent stone former who've had previous open stone surgeries. We have quite a few of them. Those who have deformities. It's more common in the supine position. And also in horseshoes, they usually have a colon over the lower pole, so you have to go for the upper pole. So the last one is cowardice is the better part of discretion. Run away early. So if there's a large amount of bleeding, sometimes you can get away with it. You can put a Ratic inside your sheath and it'll stop. If you go look again, sometimes those clots do help if you've got a whole bunch of little fragments, because it sticks, the little stone fragments stick and you can pull them out. But if there's real bleeding, there's no shame to run. It's actually the more clever thing to do. If you need to put in that K-nephrostomy or the Nephromax to at low pressure just to tamponade the tract. If the procedure gets too long, think, watch yourself. 1 hour to 2 hours. If a patient's lying prone or lying on a wet bed and you're infusing large amounts of saline into that system under pressure, you're going to run into trouble. So I'd rather do it as a staged procedure, come back another day. And the other advice is, as I said before, don't overpromise, rather underpromise and overdeliver. If you can't get to all the stones, we have multiple modalities that we can use. You don't have to clear the stone. You can try to clear the pelvis. That will probably make the patient feel a lot better. But we have so many other modalities we can use to get the other pieces out. So incomplete clearance is not a disaster, especially in the high stone burden patient. So what we do at Critical Care, all of our patients, we do pre-op CTs. In the staghorns and the chronically obstructed kidneys, we do renograms. We don't want to do operations on non-functioning kidneys. We'd rather do a lap nephrectomy then. All of them get a pre-op culture. All of them get a group and screen. We tend to plan our tracks and our supine or prone approach pre-operatively, but sometimes you have to decide a supine prone on the table, depending on what your axis is like on your ultrasound view once the patient is positioned. So this is actually a picture from Twitter at Pablo Cambises, who's actually doing this patient supine. This is unfortunately the kind of the trend that we're seeing in our practice, more and more incredibly obese patients. And this is why we started to do supine PCNLs, because we've had patients who we couldn't prone purely because of their body habitus. So we always use an ARVID too, because, as I said, we often make the decision on the table whether or not we're going to do a supine or a prone. So we used to use a bolster underneath the shoulder and the buttock, but this is the Evans Puckley roll. Somehow he decided that the solid roll was better, so then we use the solid roll. We literally just use it to lift the patient off the bed. The patient's right on the edge of the bed. And another thing that we do is we just check that the contralateral hip is not, we often have to put something underneath. We untorque the patient, because if you just lift up the one side, they have to lie on top of this roll, because if you just lift the one side up, it tends to rotate the patient. And when you screen, you tend to just see the spine. So just one thing is just rotate the hip back so that the hips are almost horizontal. So we often put a 1 liter saline vacuoliter under the other hip just to level out that pelvis so they're not torqued too much. When you're starting out, it's always useful to just check that your position is okay. Use your C-arm just so that you definitely can reach there. It's a little bit of a pain if you can't see with a fluoroscopy when you need to. We're quite lucky. We have this expensive table that can move horizontally. If you don't have that, just make sure that when you do that, that you can actually get in with your C-arm. We also drape one time when we do supine, so we do the putting in catheters and everything, and prepare the side before we start, and that does cut down on time. So these are the other positions. We actually did start with the 2 bolted, as I said, but we're now using a solid roll, and it works very well. So this is the ultrasound that we do. You can see in the picture on the left is one of ours. You can see the stone. Sometimes you can't see the collecting system that well, but you need to put some saline into the system to kind of create that contrast. Just to show you here on the other side, this is the best picture I could find actually, which shows a very good example of a dirty shadow versus a clean shadow. So a stone gives you a clean shadow. The dirty shadow is bowel. It's that classic shadow you see when you're looking for the kidney, and under the liver, you just see this mess that looks like what you can see on the side where it says dirty shadow with an arrow. So if you're not sure if it's the liver, you're not sure if it's the lung, you're not sure if it's colon, go to where you definitely know it's going to be the colon, look at the colon, then come back to the kidney. And then if there is some colon sitting behind that kidney, you'll notice it. The liver and the spleen is easy enough to see. If you're doing supine perks, you're probably going to be too low to actually hit the lung. So I think ultrasound as much as possible is a little bit different from what you're used to in the normal day-to-day practice, but it's not a far stretch. It's actually a very easy to transition to doing ultrasound perks. This is our prone setup. I used to do almost all my perks prone. We've pretty much moved more to the supine for most patients, but we still do a fair amount of prone PCNLs. And the reason we've moved to supine is during the lockdown, the anaesthetists were very upset with us doing prones and said, what happens if a patient needs house care or ICU and we don't have that available? So we started doing a lot more supines, and that's pretty much the majority of our PCNLs are now supine. So the kit, we have obviously the normal stuff, the 2-part needle. You can decide which one you want, the one that's a pencil point or a bevel. I preferred the bevel one. We always have a 2 ml syringe, always have blue stuff, and a selection of guide wires. I like to use a high wire, which is a hydrophilic stiff wire, but we always have the floppy ones. The stiff ones you can't get into a small calyx, especially if the infundibulum is blocked by stone in a stag. So it's better than to use the softer wire. If you try and force a high wire into a small calyx, it will rip the whole calyx apart. I used to use the J wire, but it's not a nice wire to dilate on because it buckles. It is if you can't get the guide wire nicely into the stone packed calyx, it does sometimes help you. But usually you can sneak a floppy hydrophilic wire in there. Another thing is if you're going to put multiple tracts, you do them right at the beginning before you dilate, because it is a little bit more challenging to get an extra tract in, especially if you've already, if you're doing an ultrasound perk, because the tract then you struggle to get the ultrasound around it and you see your sheath. So we also use a special plastic drape. You can also use plastic sheets. We always use a double irrigation set. Obviously, you need a bucket, otherwise the floor's wet and the anaesthetist gets upset. In terms of tract dilator, we always have amplats and the nephrostomy balloon dilator with the sheath. We use usually the 30 French. If we want to go smaller, we use the amplats. The amplats is quite useful, and we often, especially when we're training somebody who's going to go back to a resource poor setting where they're not going to be able to afford expensive balloons, then the amplats is really useful. It's also useful in difficult tracts or very fibrosed tracts. The nephroscope, the grasp with one of those Dormier baskets with the red handle, and then the lithotripter, whatever you're using, ultrasonic ballistic, and then obviously a drainage tube, whatever you want to use, a Foley's catheter, or one of those really smart Malakots. So the perk, I do my perk ultrasound. When I do a supine perk, I try never to go for the extreme lower pole, except if there's a stone in there and I won't be able to reach it from one of the mid-zone cases. Usually I aim for the calyx, which is just above the lower pole one. It gives you better access to the rest of the system. And also I try to perk as far forward as possible without going through bowel. The reason for that is it just improves your angle into the into the rest of the kidney. So if you're perking from an extreme lower pole, you often run into trouble with a scope in the patient's hip, or even with this, the attachment of your stirrups. So we like to go for the one just above. Once we actually have the needle in, we will check the position with screening. If we don't get blue immediately back, we usually put blue through the ureteric catheter. If it's not in, it's usually a little bit too far, because you see the system on the ultrasound, you get very excited and push it in too far. So usually pulling it back with a little bit of aspiration with the 2 ml syringe tends to get you into the system. Sometimes you can feel the stone, that does help, and you might not get contrast back if the stone is packing the infundibulum. So then you just take a little bit of contrast in a 2 ml syringe, and under continuous screening, just trickle a little bit in, and then you'll see the ghost outline of the calyx, and you know you're in, even though you're not getting blue back or large amounts of fluid back. I've already spoken about putting all the guide wires in first. I found that the best way to secure the other guide wires is to stitch them in with nylon. It's a pain to get the stitch off, but it's the best way to keep them in. Otherwise, when you try to stick them down with opsites and other things, they tend just to jump out while you're busy with the other tract. I always dilate the money tract first. What's the money tract? The money tract is the one that's going to get me the bulk of stone clear, and that's usually the tract that leads me straight to the pelvis. Often what happens if you dilate the money tract, you get so much of the stone out. And once you've done that, you might find that the upper pole ones, or the ones higher up, once you've cleared the pelvis, tend to start falling into the pelvis, and you might not even use the other tracts. One other thing which is incredibly important is you need to train your team, and especially you need to look at the bucket, not to look at the screen. Because if you're looking at the screen, you often don't notice if your sheath has slipped out a bit, you might get profuse bleeding from around the scope coming out the sheath, which you don't see, and you can lose a huge amount within a few minutes. Okay, so one other thing we do is rescoping the tract. So if you leave a tube in and you have some fragments, you can go and do that under local with a flexiscope and just a plain Dormian basket. Use the bigger one, not the 1.5 days to week, the bigger ones. And we often get large amounts of fragments out, and you can avoid another procedure. Okay, so I think we're running short of time, but I have a few cases. I'm just going to show you 2 cases then. I have quite a few more. I'm just going to show you 2 just to illustrate, why we pick, or how we look at picking prone and supine. So these are cases we've done in the last 2 months. So this is a cystine uric patient. You can see he's got a high stone bulk, well-known patient. This is probably the 4th PCNL he's had. He's also had open stone procedure on that kidney, and he's only got 1 kidney left, and he's got CKD. So if you look at the stone, you can see that there's not a great window there with the spleen on that side. And so we chose to do a prone approach in this patient, also because we knew we wanted to do two tracts, upper pole, we wanted a true upper pole tract and a lower pole tract. So we got quite a fair amount of stone in this patient. We actually took him back to rescope the tract and got up a bit more. He's not stone free, but I don't feel too bad about that. He is a cystine uric, and there's quite a lot of stone in that system to begin with. So this is another patient we also did in the last month. So also high stone burden, whole pelvis full. If you look there on the one side, you can see there's an organ there we don't want to perk. That was more to the mid upper pole. But if you go lower down, you can see there's a better window to do a supine perk. So that's what we did. And we actually were able to clear most of the pelvis. You can see, unfortunately, he still has some stones in the upper pole. We were able to pull out a few fragments, but he still has that one calyx that's packed full. That's not going to come out. On our original retrograde, when we did his procedure, you could actually see that had like a triangular shape. So that's definitely not going to come through that infundibulum. So he's going to need another procedure for that stone. Okay, so just one other, in terms of the supine PCNL is another great use as a patient like this. We have a retained stent. We've basically been doing just retained stent for up until probably about a month ago, post COVID. And the supine approach is really ideal for this kind of patient, where we position them supine, we do a perk. We try and get a ureteric in next to this retained stent, which you can't always do, but you usually can. And if you can't blow up the system very much, you can always just perk onto the stone. And then we try and clear the pelvis as much as possible in whatever fragments in the what usually you can only clear the calyx that you come through. And then we'll proceed to whatever management is required for the bladder side. And that's generally open cystolithotomy for a stone like this, because they're just too large and hard. And in almost all patients, this approach will get the stent out. You might have a few fragments left in the kidney, but at least you'll get the bulk of the pelvic stone and the bladder stone out in a single procedure. So that's become our single-step approach for retained stents, which we feel is quite a good management, as opposed to in the past where they'd need 2 or 3 operations. So I'm going to leave it there because we're at 8. John, is there any questions?
Belinda, that sorry, I'm talking to Belinda on. Yeah, apologies. A privilege to hear that talk. Wonderful to have an expert giving some advice, and perhaps you'd like to advertise. I don't know if that's for public knowledge, but you're doing a workshop in the next couple of weeks. Yeah, we are. I think it's a small workshop, and we will try and broadcast it. That's the 31st of May and the 1st of June, and it's going to be specifically a supine PCNL workshop. Fantastic. Are colleagues able to join? Would they be welcome? Is it something? Yes, they would be. Apparently, if you're happy to help us with the broadcasting, I'm happy to have them join. Yes.
That's fantastic. And there are a couple of questions. I don't know if you want to quickly look on the chat there. Okay. Thanks. Okay, so where do we start here? Is ultrasound, is ultrasound for guide wire placement when dilated then? Yes, so we use a hybrid approach. So we put all the guide wires into the ultrasound, and then we dilate under fluoroscopy. So I've done a few workshops with Graham Watson, and in some places it's difficult to find a C-arm, and I can tell you it is difficult to dilate without fluoroscopy. There are a few series from China where they do complete ultrasound perk, but I just, in my hands, that I don't feel comfortable with that, because there's certain things that you can't see. Yes, you can look at the depth that you're putting your dilator in. You can feel the give of a dilated collecting system, but it is very difficult to note if the kidney is pushing away. If you've spatchcocked the kidney, you don't see that if you're not using fluoroscopy. We use very little fluoroscopy, but yes, we do use fluoroscopy for dilation, and in my hands, that's the safest. So there was another question. In which scenarios would you decide against supine? Any experience and thoughts on a combined? Yes. So no, we do often do this. So actually, I do have a case that I can show you where you can use both. So we wouldn't really go supine in a patient where we don't have access. So there's two patient groups where I usually wouldn't. The one is where I know I want to do multiple perks. The other one is where I want to do an upper pole perk. And yes, there are patients where you just can't find a good window because either one of the spleen, liver, colon is in the way. And in those cases, I have got a few patients where you really just have to pick something else, and that's either you have to laser, and there are series where people have lasered full stags. I don't know, I don't have that patience, but that is possible. But also don't throw Eswell away. Yes, your risk for a Steinstrasse is much larger, but you can do combined treatment. Beautiful ureteric jet on the program. Yes, it is quite beautiful. So there is a case that I can show you where we actually had a lady who had quite a big, she had, where is this? We had a big, okay, so this is the lady we did a pushback on. So she had this big stone in the ureter, and we thought we were going to eat that forever. So what we did was we perked her, and we fished that stone up. So you can see she's very hydronephrotic, and she's got this proximal ureteric stone. So we did a mid-zone perk and went down there, and actually the stone was a bit jammed in. So we then used a UV rhinoscope to push the stone up, and then it was easy to grab in the pelvis. So you can use that. You can even go up into the pelvis. The supine gives you that option, and you can take stones and reposition them. So sometimes you can't get around the corner with a flexible cystoscope. We use that quite a lot intraoperatively. So if there's a stone sitting in another calyx, you go in with a flexible cystoscope and fetch it. But sometimes if the two calyces are next to each other, you can't get it around that corner. And then you can put a flexiscope in from the bottom. The only thing is you've got to do that early, because once there's bleeding, your flexible UV trainingscope doesn't give you very good vision because the flow is not good enough. So just make that decision early, and then you can move the stones all over. And also just be aware, if you're doing a stone like this, your baskets limit how big you can pull, and you have to do that with a flexible scope. You can't go around the corner with a rigid unless you do an upper pole and have a straight shot. You have to just be careful, because you can injure the PUJ. Were there any other questions? No, that's it.
Lisa, just one last one from me. Lyticos tells us that we can perk onto the pelvis, or we don't have to perk onto the papilla.
Yes.
Yes, that's true. That you've tried? Is that something you tried, and do you believe him?
No, so he's got actually good. There's a good study that I think they've got about almost 30 patients in both arms, where they literally went and randomized the patient either getting perked end on or papilla. And I think we always tell ourselves that we're perking end on, but we're not always. And sometimes when you have a big stone, which the calyx is packed, and you hit it end on, when you dilate, you tend to run into the side of the thing, and you land up in the infundibulum. So I think we often think, yes, we're end on, but we aren't. And in my experience, the biggest problem in terms of running into bleeding is when you torque the scope within the kidney, or if you don't have the sheaths within the collecting system. So I agree with him. I think from our kind of our experience, sometimes you're a bit off, and it doesn't seem to make a huge difference in the interpolar region, and there is good evidence to support that.
Lisa, I can't see any further questions. It's been a privilege listening to you talk about your tips and tricks. I think it has helped colleagues around the country to progress from prone to supine. So thank you very much.